In every hospital, one word can create pressure across departments. Urgent. For the ward, it may mean a patient waiting for discharge. For emergency department, it may mean a decision that cannot wait. For ICU, it may mean treatment changes within minutes. And for the laboratory, it may mean dozens of samples arriving at the same time, all marked urgent. Tonight on Beyond The Shift Oman, urgent means urgent. Isn't it?
Salam everyone. Welcome back to Beyond The Shift Oman. I'm Mohammed. And today's episode is going to be different because we are not talking from one department only. Today we are bringing ICU, the surgical ward, medicine OPD, and laboratory into one conversation. And the topic is something every hospital staff knows very well. Urgent investigations. Why do we request them urgently? Why do results sometimes feel delayed? What is happening inside the lab before the result appears? And why does every department feel their request is the most urgent one? Isn't it? So today we are going to talk honestly, respectfully, and hopefully with some laughing also.
Salam everyone. I'm Fatma. I'm a senior staff nurse from ICU, and from ICU side, urgent investigations are honestly part of daily life. Sometimes one result can change the whole plan immediately. Potassium, ABG, lactate, coagulation, renal profile. These are not just numbers for us. Sometimes we are literally waiting for the result to decide what happens next.
Hi everyone, I'm Mariam. I'm a senior staff nurse from the female surgical ward. And from ward side, honestly, lab investigations can affect everything. Doctor rounds, discharge plans, operation preparation, post-op monitoring. Sometimes one pending result can delay the whole patient flow. And of course, the patient and relatives keep asking us, "Sister, result came or not?" So yes, we also feel the pressure.
Hello everyone, I'm Nadia. I'm a senior staff nurse from Medicine OPD. In OPD, the pressure is different. We have many patients waiting, doctors trying to make decisions quickly, and sometimes patients need results before they can go home or be referred. So from our side, when we call about a result, it is usually because the patient is sitting there waiting and asking every few minutes.
Hello everyone, I'm Sarah. I'm a senior laboratory staff, and I'm happy we are finally talking about this topic. Because sometimes from outside the lab, people think the sample goes in and the result just comes out magically. But inside the lab, there is receiving, checking, labeling, processing, analyzer time, verification, critical values, repeated phone calls, and sometimes rejected or hemolyzed samples. So yes, urgent means urgent, but sometimes everybody writes urgent, isn't it?
Okay, Sarah, I think we have to start with you. Because every department says the same sentence. Please, this is urgent. ICU says urgent. A and E says urgent. Ward says urgent. OPD says urgent. And the lab receives everything as urgent. So from lab side, when everyone writes urgent, what happens actually?
Honestly, Mohammed, this is exactly the problem. If one sample is urgent, we can prioritize it clearly. But if every sample is urgent, then urgent starts losing meaning, isn't it? Sometimes we receive samples from ICU A and E, wards, OPD, all together, and each one comes with phone calls saying, "Sarah, please fast." But inside the lab, we still have to receive the sample, check the label, check the request, process it, run it on the analyzer, verify the result, and sometimes repeat the test if something looks wrong. So, from outside, it looks delayed. But inside, there are many steps before the result appears.
I understand that, Sarah. But from ICU side, sometimes we are not calling because we want to disturb the lab. Sometimes the doctor is standing beside us asking, potassium came, magnesium came, lactate came, and the patient condition can change quickly. So when ICU calls, it is usually because the result can change treatment immediately. But yes, I agree. Maybe not everything should be marked urgent.
From ward side also, sometimes the pressure looks different. Maybe the patient is stable, yes. But discharge is waiting, doctor round is waiting, operation preparation is waiting, relatives are asking every 10 minutes, and the nurse becomes the middle person between doctor, patient, relatives, and lab. So when we call, sometimes it is not because we want to rush people unnecessarily. It is because everyone is asking us at the same time.
Exactly, Mariam. In OPD, sometimes one result decides if the patient can go home, needs admission, or needs urgent referral. And we have many patients waiting outside. The patient sees us sitting there and thinks we are doing nothing. But actually, we are calling, checking, following, asking the doctor, checking the system again. And sometimes the result comes after the patient has already asked us 20 times. So yes, the lab is busy. But OPD also becomes under pressure from the waiting area.
Sarah, I think this is the part many staff outside the lab don't see. Because from ward side or ICU side, we send the sample and then we look at the system waiting for the result. But inside the lab, there is a full process happening, isn't it? So explain it to us like we are staff sitting in the nurse's station waiting impatiently.
Exactly. The sample does not just enter the lab and magically become a result. First, we receive it. Then we check the patient details, sample type, request, label, time, and condition of the sample. If the sample is hemolyzed, clotted, insufficient, wrong tube, wrong label, or leaking, we cannot just process it and pretend everything is okay. Then the sample has to be processed depending on the test. Some tests need centrifuging, some go directly to analyzer, some need manual checking, some results need verification before release. And if the result is critical, we also have to communicate it properly. So when people say, why result not showing yet? Sometimes the result is not delayed. The process is still happening.
Honestly, this is the part we forget sometimes. Because in the ward, we are just seeing pending result. Pending, pending, pending. And the doctor is asking, relatives are asking, patient is asking. So we forget that the sample itself may still be going through many steps. But Sarah, I have to ask, sometimes we call because nobody updates us, isn't it? So communication becomes important also.
Yes, communication is important, but also imagine this situation. One lab staff is handling samples, checking results, answering doctors, answering nurses, verifying critical results, and then the phone keeps ringing every 2 minutes. Sometimes the phone call itself delays the work. I know people call because they are under pressure. But inside the lab also, the person answering the phone may be the same person trying to release the result. So sometimes if we reduce unnecessary calls, the result may actually come faster.
That is fair. But from ICU side, sometimes we call because we don't know what is happening. If the sample is hemolyzed, rejected, delayed, or still processing, we need to know early. Because if we keep waiting and later discover the sample was rejected, that becomes dangerous for us. So maybe the issue is not only calling. Maybe the issue is clear communication both ways.
Okay, so now let us talk about real urgency. Because sometimes the word urgent is used too much, yes. But sometimes urgent really means urgent. For example, in ICU, A&E, or any unstable patient, one result can completely change the next step, isn't it? Sometimes you are waiting for potassium before giving treatment. Sometimes blood gases changes ventilation decisions. Sometimes Lactaid tells you if the patient is going worse. Sometimes troponin or coagulation affects the whole plan. So the issue is not that urgent requests are wrong. The issue is knowing which urgent request is truly time critical.
Exactly, Mohammed. From ICU side, sometimes we are not asking for fast results because we are impatient. We are asking because the result can change treatment immediately. If potassium is very high, we need to act. If ABG is bad, ventilator settings may change. If lactate is rising, the team becomes more alert. If coagulation is abnormal, procedures or bleeding risk become serious. So from ICU side, every minute can feel heavy. But at the same time, I agree with Zara. We also need to avoid marking everything urgent without thinking.
Yes, Fatma, and honestly, laboratory staff understand that. We know ICU samples are often critical. We know A and E samples can be urgent because decisions depend on them. The problem is not real urgent cases. The problem is when routine work is marked urgent just to make it faster. Because then the lab has to sort everything again mentally. We start asking which one is truly critical, which one is urgent because the patient is unstable, which one is urgent because somebody wants the result quickly. These are different things.
Sarah, I want to ask something from OPD side. Sometimes OPD request feels urgent because the patient is sitting there waiting. Maybe the doctor needs to decide admission or discharge, but maybe from lab side, compared to ICU or A&E, this is not the same urgency. So how should OPD staff understand this? Because for us, the waiting patient feels urgent too, isn't it?
This is a very good point. Urgency has levels. A patient waiting in OPD is important, definitely, but an unstable patient in ICU or A&E may be time critical, so maybe we need to separate urgent from time critical. If every request is urgent, the lab still has to prioritize based on patient condition, test type, critical care, area, and clinical need. That is why clinical information helps us. If the request only says urgent but gives no clinical reason, it is harder. But if the request says unstable patient, suspected sepsis, severe potassium abnormality, chest pain, or post-arrest, then lab staff understand the urgency much better.
That makes sense. Maybe from ward side, we also need to be more clear. Because sometimes we only write urgent and expect everyone to understand our situation. But maybe the lab cannot see our ward pressure. They cannot see the doctor standing near the counter. They cannot see relatives asking. They cannot see the discharge waiting. So maybe writing the correct reason or communicating clearly is better than just repeating urgent again and again.
Sarah, now let us talk about something that creates stress for everyone. Rejected samples. Because from nursing side, when the lab says sample hemolyzed or clotted or wrong tube, honestly, everybody becomes frustrated. The nurse feels tired because the patient may be difficult to cannulate. The doctor becomes upset because result is delayed. The patient gets another needle. And the lab says they cannot process it. So explain this part clearly. Why can't the lab just run the sample sometimes?
This is very important. Sometimes people think laboratory rejects samples because we want to make life difficult, but actually rejection protects the patient. If the sample is hemolyzed, clotted, insufficient, wrongly labeled, wrong tube, leaking, or contaminated, the result may become inaccurate, and an inaccurate result can be more dangerous than a delayed result, because then the doctor may treat based on wrong information. So when lab rejects a sample, it is not personal, it is patient safety. Believe me, lab staff also don't enjoy calling wards and saying, "Please recollect." We know the nurse will not be happy.
I agree it is patient safety, but from ICU side also, sometimes recollection is not simple. Some patients are edematous, some have poor veins, some are on vasopressors, some already have multiple lines. Sometimes one blood sample takes real effort. So when the sample comes back rejected, emotionally it is difficult for the nurse also. But yes, I understand. Wrong result is dangerous.
In the ward also, difficult veins are a real problem. Some patients are elderly, some are post-op, some are dehydrated, some already had multiple blood collections during admission. Then the patient says, "Again, sister?" And you feel bad. So when sample is rejected, the nurse becomes stuck between patient discomfort, doctor pressure, and lab quality requirement. It is not easy from any side.
In OPD, rejected samples also create patient dissatisfaction quickly because the patient may already be waiting long. Then we tell them we need to repeat the sample. Sometimes they become upset. Sometimes they say, "Why you did not do it properly the first time?" And again, the staff at the front gets the reaction, even if the issue is technical or sample quality.
So basically, everyone suffers when the sample is rejected. The lab suffers because they have to call and explain. The nurse suffers because they have to recollect. The patient suffers because they need another sample. The doctor suffers because the plan is delayed. So maybe the best solution is not blaming each other. The best solution is reducing preventable sample problems as much as possible. Correct tube, correct label, enough volume, proper mixing, proper transport, and if rejected, clear communication as early as possible. Let us talk honestly about phone calls now, because I know this topic will make everybody smile a little. Every department calls the lab. The lab gets tired from calls. The ward says, "Nobody updates us." ICU says we cannot wait. OPD says patient is sitting there. So Sarah, from lab side, how does it feel when the phone keeps ringing?
Honestly, sometimes the phone becomes another machine inside the lab. It keeps ringing. And the difficult part is that the person answering may be the same person processing samples or verifying results. So every phone call interrupts concentration. Sometimes people call and say, "My result," but they do not give hospital number quickly. They do not give test name. They just say, "Patient from ward." Then we need to search, ask again, check system, and this takes time. So calls are sometimes necessary, but unnecessary calls can delay the same work people are asking about.
That is true, but I will be honest also. Sometimes we call too much because we are under pressure. Doctor asks us, patient asks us, relatives ask us. Then after 5 minutes, another person asks again. So the nurse becomes nervous and calls the lab again. Not always because we want to disturb, sometimes because we have no answer to give people.
Same in OPD. If patient is waiting, every minute feels longer. They keep looking at us. Sometimes they ask, "Did you check?" Then after 2 minutes, "Now?" Then again, "How long?" So staff start calling because the pressure is in front of them physically. But yes, I understand if everyone calls, lab work gets interrupted.
From ICU side, I think calls should be more targeted. If it is truly critical, we call. If the patient is unstable, we call. But maybe we should avoid calling repeatedly without new reason. Also, lab can help by informing early if sample is rejected or if result will take longer. because uncertainty makes staff call more.
Exactly. If there is clear communication, calls reduce. For example, if lab informs early, sample hemolyzed, sample received and processing, machine maintenance. Result needs verification, then departments understand better. And from department's side, when calling, give clear information. Patient number, test name, department, reason for urgency. Then the call becomes useful instead of stressful.
Okay, now I want each one to give one practical thing. Not big policy, not perfect hospital dream, just one realistic thing that can make lab and departments work better together. Sora, start with lab side.
From lab side, my first request is proper sample and proper information, correct label, correct tube, enough blood, clear request, and if it is urgent, write why it is urgent. Not only urgent, give clinical reason, because when we understand the reason, we can prioritize better and communicate better.
From ICU side, I think we need better communication when samples are delayed or rejected. If lab informs early, we can recollect early. We can update doctors. We can adjust the plan. Waiting without knowing what is happening is what creates stress. So early feedback is very important.
From ward side, I think we need to organize our samples better, especially during rounds. Sometimes many investigations are requested at once. If we plan properly, label carefully, and avoid rushing sample collection, we reduce mistakes. Also, we should avoid marking everything urgent just because doctor round is happening. Not everything is truly urgent.
From OPD side, I think patient communication is important. Sometimes, if we explain clearly that results take time, patients become calmer. But staff also need realistic expected times. If we know approximately when result may come, we can manage the waiting area better. Uncertainty makes everyone stressed.
So the common point is communication. Correct sample, clear priority, early update, less unnecessary calling, and understanding that every department is seeing pressure from a different angle. The lab sees the sample load. ICU sees unstable patients. Ward sees doctors, relatives, and patient flow. OPD sees waiting patients and clinic pressure. If we remember that, maybe the conversation becomes less blaming and more teamwork. Okay, after all this serious discussion, I have to ask something. Sarah, be honest. When the same department calls the lab 5 times in 10 minutes, do lab staff recognize the voice already?
Of course, sometimes we recognize the voice before they say the department. We hear hello, and we already know. This is ICU, or this is ward, or this is OPD, asking about the same result again. But honestly, we understand. We complain a little inside the lab, then continue working, isn't it?
Same in the ward. We also recognize lab calls immediately. When the phone rings and someone says, sample rejected. Everybody at the nurse's station looks at each other like, please not my patient. It becomes a whole emotional moment.
In OPD, the emotional moment is when patient asks, result came? And before you answer, another patient behind them also asks, mine also? Then suddenly you are managing a small press conference near the counter.
In ICU, when the doctor asks about potassium for the 3rd time, the nurse starts checking the system with fear. Not because of the lab only, because you know if the result is abnormal, the whole shift is about to become more interesting.
This is exactly why these conversations are important. Because every department has its own stress, but also its own comedy. And sometimes hospital staff survive difficult shifts because they can still laugh together, even if the laugh comes after a rejected sample.
Honestly, I hope people understand that laboratory work is not invisible work. Behind every result, there is a process. There is staff checking, processing, verifying, answering calls, handling critical values, and trying to release accurate results safely. We know departments are under pressure, but the lab is also under pressure. At the end, all of us are serving the same patient.
And from ICU side, I think this discussion is useful because sometimes we focus only on our urgent patient, but we forget the lab may be handling urgent requests from the whole hospital at the same time. Still, for critical patients, communication must be fast and clear. That is how we protect patients together.
From ward side, I think we need to understand the process better. And also, we need to improve our own part. Correct samples, correct labels, better timing, clear communication. Because if one small mistake happens during collection, the delay affects everyone after that.
From OPD side, I think expectation is important. Patients wait, doctors wait, staff wait. But if we communicate better and understand the reason behind delays, the stress becomes less. Not gone completely, but less.
I think this episode shows something important. Many hospital problems are not caused by one department. They happen between departments, between pressure, timing, communication, workload, and expectations. And maybe the solution starts when we stop saying why they are delaying us and start asking what is happening on their side also. That small change can improve teamwork a lot. Sarah, Fatma, Mariam, Nadia, thank you all for this honest discussion. And to everyone listening from any hospital department, urgent means urgent, but understanding each other is also urgent, isn't it?
Behind every urgent request, there is a patient waiting. Behind every delayed result, there may be a process nobody sees. And behind every department, there are staff trying to do their best under pressure. This was Beyond the Shift Oman. Episode 3. Urgent means urgent. Isn't it? The conversations, thoughts, and reflections in this podcast are inspired by real healthcare experiences and realities familiar to every hospital staff. Now you can listen to this podcast on Spotify, Apple Podcast, YouTube, and many other podcast platforms. This project was shaped, written, edited, and produced by Talal Salim, creator and executive producer of Beyond the Shift Oman. Good night, and see you beyond the next shift.